Добрий день, шановні колеги та партнери. Ми дуже раді, що ви маєте змогу приєднатися до ефіру сьогодні. І на початку я хочу перевірити, чи Менді чує нас, наразі через перекладачів.
Yes, I can indeed. Thank you.
Все добре, Менді нас чує. Тоді я хочу наголосити, що ми починаємо наступну серію прямих ефірів і фактично другого сезону вебінарів, які присвячені катамнестичному спостереженню, тривалому догляду за передчасно народженими дітьми, за дітьми з будь-якою перинатальною патологією. І я сьогодні хочу представити вам Манді Daly, це голова Ірландського неонатального альянсу. А окрім цього, Дейлі ще і мама передчасно народженої дівчинки. Також вона має великий досвід адвокації, підтримки, дослідницьких наукових робіт, все, що стосується катамнестичного спостереження та тривалого догляду за дітьми, які народилися передчасно. Менді має більш ніж 70 досліджень, в яких вона приймала участь і національних, і міжнародних. Зокрема, вона була членкинею команди, яка створювала стандарти догляду за передчасно народженими дітьми. Вона є тренеркою програми NIDCAP, і також вона має величезний досвід клінічного аудиту та оцінці медичних технологій як в сфері акушерства, так і в сфері неонатології. Окрім цього, вже 3 роки поспіль Менді підтримує Україну, і я знаю, що це вже 3-й раз, коли вона буде представляти нам результати свого досвіду та досліджень. Ми дуже дякуємо вам за це, за шалену підтримку українських малюків під час війни. Якщо ви нас гарно чуєте, я прошу вивести на екран презентацію і передаю слово Менді.
Thank you so much for that lovely introduction. I'm just about to share, and somebody might confirm that you can see my presentation. Perfect, thank you. So the title of my presentation today is Prematurity and Beyond. And as was mentioned, I am a parent of a preterm infant. Her name is Amelia Faith. She was born 19 years ago at the end of week 25, and she weighed 780 grams. This was not what I expected from my pregnancy. It was not the outcome I wanted, but to say it has shaped every single day of my life since is an understatement, I suppose, in many respects. I'd like to start by saying that everything that happens in a neonatal unit has an effect. That can be positive, negative, or cumulative, and each effect has the potential to last a lifetime. And we know now from research that parents and families are the greatest buffer against those adverse effects of the neonatal unit. So what was parenting like in the neonatal unit? There isn't a book that describes how to parent when you've had a preterm birth. What for me represents my preterm birth is I lost the joy of my pregnancy. I lost all those lovely memories that I'd hoped to make in that last trimester. I lost the birth plan that I wanted. My baby was taken from me through cesarean section because I had a placenta abruption. I was totally out of control of most of my pregnancy. It was high risk, and it ended in such an abrupt fashion. It deprived me of lots of those happy moments that I had anticipated. I didn't get to hold my baby first. Somebody else held my baby. My baby's first experience of this world was pain, fear, invasive procedures, not warmth, love in the arms of parents. And that's something that actually stays with parents, whether we realize it or not, for a lifetime. We can never get those memories back. They're gone. And a lot of what happens in the neonatal unit should be about recreating memories for families. We come to the neonatal unit, not just with our baby, we come as a family. It's a mum, it's a dad, it's grandparents, there are siblings involved, and the ripple effect of preterm birth just keeps on going. And the emotions associated with it, they're not all of what we associated with birth. There isn't all that happiness and love. Yes, it's there, it's bubbling under the surface, but it's absolutely superseded by fear, loneliness, anger, guilt, aggression, being lost. And we're trying to navigate that really difficult roller coaster journey of emotions while still trying to find our role within a NICU as parents. For me, it was 24 hours before I saw my child for the first time. And in that period of time, it's like being suspended in animation. Nothing is happening. You've had a baby, you don't see that baby, you don't know what's happening to that child. And it's like everything has come to a standstill until you get to see that infant. And when you do get to see that child, sometimes you don't recognize them. In my instance, I didn't know who my child was when I was brought to the neonatal unit to meet her. She could have been any of those 10 babies that were fighting for their lives in their incubators. And I didn't feel like a parent. Preterm birth flips the paradigm of parenthood on its axis. It deprives us of our joy, our hopes, our expectations. And we do spend a lot of time sitting on the sidelines, watching others do what we had hoped to be doing. We're essentially visitors in a world that we possibly never knew existed. And by visitor, I mean, sometimes it's the small things, walking down that corridor to gain access to the neonatal unit, which is often behind a locked door. We don't have access unless we hit a bell, hit a buzzer. We wait for somebody else to bring us into that world. And that in itself is an obstacle. That in itself is a surreptitious message that you are a visitor here. You are not part of this world. You can come and see your baby, but we are in charge of what's happening. Those little messages on the doors of our neonatal units, which often will be like the times that you can visit, when you can't visit, who can visit, who can't visit, when staff handover is happening, parents are often expected to leave the neonatal unit. All of those rules are obstacles that prevent us from being parents in this new world. And it's something simple, but many units have managed to navigate around this. Many units now find ways of helping parents access the unit, welcoming them in, giving them a swipe card so they can come and go when they feel like it. This is their home. It is their home for an indefinite period of time. They are trying to be parents in a world that they never knew existed. And we don't often do enough to welcome our families in, to make them feel at home, to help them find that parenting role in a world that is very new to them. Parenting in the NICU is hard. It is very difficult to parent when there is a perspex wall between you and the only thing in the world that is full of love. That is your heart in that incubator. And you don't know what to do. And I think it's really important to acknowledge our family's difficulties, which we don't often do. We often concentrate on relaying to the family what is happening to the baby today, what we're doing, what is going to be happening tomorrow, without often standing back and wondering, how are they perceiving what's happening? How are they managing as a family to navigate this new journey? How are they feeling in themselves? In many instances, Mum may have had a really high-risk pregnancy. Mum may have nearly lost her life. Mum mightn't even be present. Mum might be in another hospital, recovering from whether it's preeclampsia or surgery. How do we navigate and how do we help those families get better to heal themselves? And we don't always have a self-care package for families. We know they're there, but the baby tends to be our main focus, when actually it should be the entire family unit, because they have all been affected by preterm birth. And they're the ones who are going to navigate the rest of their lives with this label of preterm birth. Yet, sometimes in the NICU, we find parents focusing entirely on their baby to the detriment of their own health. And it's always really good to sort of step back from the baby and have a look at the extended family and see what support they may need to help them be the best parent they can in that environment. For me, it was traveling 2 hours to the hospital every day, spending 14 hours at the baby's incubator, 2 hours home at night. and often forgetting about myself. All I wanted was my baby to be better. I wanted to scoop her up and go home with her, no matter what was wrong. And that was really hard because I didn't get to hold my daughter for 4 weeks. She was very, very unwell. I hadn't received antenatal steroids. She was on life support and she was struggling. There were very few days in those early months where I had any hope. But for me, it was important every day to go home, to bring some element of hope with me because I was leaving part of me in an incubator to go home to a cold, dark house with no food, where no housework had been done in months. And it was like leaving two worlds apart. And it was really difficult to mentally navigate that. It was difficult to leave the hospital. Your heart is breaking because you don't know, is that the last time you're going to see your baby? You just simply don't know in those early days. And every single day doing that for 3 months solid and coming back the next day, hoping that you wouldn't get a phone call during the night. And often I would ring during the night because for me, I needed to know that things were okay. I was afraid that they mightn't ring me if something was happening. You spend a long time going from crisis to crisis in a neonatal setting. Your baby stops breathing, your baby gets infections. And whilst these are all normal for preterm infants, it is not normal for families to see their baby suffering. Parents don't have the same version of normal that healthcare professionals who work in the neonatal unit do. And I think we do need to remember that. So, and not to dismiss things, telling you that, oh, this happens to all premature babies. It happens to my baby right now, and it's breaking my heart. And I think the words we use, the way we interact with our families, can help them navigate those daily crises because we live on our nerves and it is not good for us to be not supported. I used to often wonder, did my baby feel pain? Because there was a lot of interventions happening. She was intubated, so there was no noise. Yet I could see from her body that she was reacting to things that were happening, and I didn't know what they were. Up to the 1980s, we thought neonates did not feel pain, and that fact still shocks me. How could we possibly think that a tiny human being does not have pain receptors, does not feel what we feel as adults? We know now that is not the case. They feel everything we do to them. And I think reassuring families that you have a pain protocol and that they can be part of that and understanding how they can help their baby be as comfortable as possible is really important. Because I wasn't able to interact with my child, I sat at her incubator for 14 hours every day. I kept a diary because I did not know if that diary was going to be my only tangible memory of her. I observed everything. I wrote down what I observed. What I didn't realize was what I was observing was my baby communicating with me. I did not have the skill set to hear my baby, to understand what her behaviors meant. And even worse, I sat there and did nothing to help her when she clearly was agitated, stressed, uncomfortable. And that's a guilt that I bring with me for the rest of my days. Heidelisa Alls is the founder of the NIDCAP Federation. And Heidelisa Alls opened my eyes to my baby 4 years after she was born. We took that diary and we took it apart and we interpreted all my observations using infant cues and infant behaviors to help me understand what my baby was saying to me. And some of it was very unpleasant. Some of it was telling me she was in a lot of pain. And to read that 4 years later was heartbreaking. But I do think now we are in a better place. We are, there are lots of programs that help us implement that framework of infant and family-centered developmentally supportive care. NIDCAP is one, Brazelton is another. There are plenty of them. But we need to do it. In my time, we did not have a framework. Care was being delivered, but there was no framework that integrated the family as part of that care package. And families need to be primary caregivers. They need to be the ones who are at the cot side being supported by the neonatal staff to care for their infant. They are going to be delivering that care at home. And I felt for me, I did not get that care. I certainly was discharged home, not knowing my baby, not knowing what she was saying, not being able to interpret her behaviors, and really navigating a very muddy water. And I felt I wasn't able to be the best version of me that I could have been. Amelia spent a lot of time in hospital. She had a lot of crises. She had so many instances of being reintubated, stopping breathing, suspected necrotizing enterocolitis, so many episodes of sepsis. It almost became normal for us to come in and have a crisis every day. But what was really important every day going home was that I didn't go home with a negative thought. I tried to take something positive from every day. And I think as healthcare professionals, we need to find that positive thought that will help that family leave the unit tonight, go home, have a good night's sleep, and come back in tomorrow morning fresh. And that might simply be the baby didn't lose any weight, or the baby gained 2 grams, or baby did well today. You know, finding that little positive experience that families can hook themselves and go home and take that hope home with them, because we're leaving everything we want in the world behind us. Peer support, I cannot explain the significance of peer support. When you have a premature baby, you think you are the only person in the world who this has happened to. You have no idea what you're doing. And to connect with others who are in a similar situation, and even better, who have been in this situation and who are at the next step of their journey, is so important. Again, it gives you that hope, but it also, I think, gives you that reassurance that you can get through this, that parenting does happen in the NICU, parents get through this, babies get through this, and there are happy outcomes. Preparing for discharge is something I don't think we do well. I think discharge planning should happen the day we arrive in the NICU. We need a journey plan for families. They need to be part of that planning process around how do we get baby from being intubated now at 25 weeks to going home, feeding by themselves, maybe on oxygen, but having those conversations throughout the journey in the neonatal unit about discharge, what it's going to look like, what's going to happen at home, how much support we are going to get when we leave. It is 19 years since I had my baby, and my baby was discharged home on Christmas Eve. And it was the scariest day of my life. It should have been the happiest. It should have been that day where you leave the hospital full of joy. I was terrified. I honestly did not believe that I had the skills to keep this baby alive. And for the first 3 years, I felt like her carer. I did not feel like a mom. I felt that I was taking a lot of hats home. I was going to be the neonatologist, the neonatal nurse, the physiotherapist, the occupational therapist, the speech and language therapist, the dietitian. I was all of those people now wrapped up into one. And I was leaving that security net behind me to go to a home with this new infant whom I didn't really know. I didn't really understand how I was going to be able to care for her. And the conversations were often about, you know, you've done it up to now, she'll be fine, she'll catch up with her other peers by the age of 2. That didn't help because internally I felt I was not ready. And again, there we go to those conversations that simply weren't happening throughout that journey in the neonatal unit, building up the confidence of your family so that when they do get to discharge, it is a happy time and they feel confident and competent leaving with their baby, knowing that even though that support network is now different, it still exists at home in the community if they so need it. I think transitioning to home is something we don't do well. There is that cutting of that umbilical cord, and there's that fear of going home, and things happen at home. Babies don't sleep at home. Babies feed differently. Babies are more agitated. But nobody tells us why, and nobody prepares us. And it's really, what we do as parents is we think, I'm doing something wrong. I'm doing a bad job. The baby's better off in the neonatal unit. So I think we need to look at how do we transition the family to their home setting so that they feel confident that if an issue arises, they can recognize it. And if things are different, they have an explanation. Babies sleep differently at home because it's not the NICU. It's a different environment. It's a very different looking, different sounding, different smelling environment. Babies feed differently because it's a new environment. Everything is different. Their routine is different. And everybody needs that bedding in time, but nobody tells us that. And by the time we do reach out for help, things often are so bad. We do end up getting readmitted because something is happening to baby or mum is very concerned. So I think some of those transition to home programs, I think they deserve so much credit. I think we need more of them, and I think they need to be embedded in the neonatal care that we deliver. Transition to home programs in some countries last up to 6 months, where some of the NICU staff visit the family in their home setting to help them bed in. How can we make a difference to families? Well, we need to involve them from day one. We need to recognise that they're primary caregivers. They're part of the caregiving team. They're equitable partners, and they're part of that decision-making process around everything that happens to their baby. I often felt I was on the sideline. I wasn't making decisions. They were being made, and I was being told about them. And that's not acceptable these days. For me, to understand what's happening to my baby, to be part of that decision-making process, it gives me the confidence to make further decisions as the baby gets towards discharge, and I feel more confident about my child. And we can only do that by bringing families in, finding solutions if they live far away from the hospital. How do we have them in the hospital every day, being part of that care delivery package? They need to be part of that multidisciplinary team. We need to have occupational therapists, speech and language therapists, dietitians, physiotherapists at the cot side from day one. And you might ask why? Because those babies are developing from the day they're born. All their motor system, their sensory system, their brain, they're all developing in an environment that their body isn't ready for. And we need to have the mechanisms and frameworks in place to support that development so those children reach their optimal outcomes. How do we do that? We do that by helping families understand what their babies are saying. Cue reading is so important. Babies speak to us all the time, but do we listen to them? Do we know what they're saying? I certainly didn't when I kept my diary, but now when I revisit it, my baby was having conversations with us. She was telling us what was not working for her. But because we didn't know how to interpret her body cues, her behavioral states, we ignored her. We continued to do what we call task-based care. So we feed the baby, we change their nappies, we do cares, without actually looking at the baby and saying, what's the baby telling us they're ready for? What behavioral state are they in? There are 6 behavioral states. I certainly didn't know they existed when I was in NICU. And the care that we deliver should be determined by what behavioral state that baby is displaying. If that baby is in a drowsy state about to go to sleep, now isn't a good time to feed. Now isn't a good time to change their diaper. Now isn't a good time to draw blood. We should be tailoring our care based on where that infant is at. We should help our families and our staff understand at what point on the developmental trajectory this baby is in terms of their motor development. Because if they need additional support, be that maybe a cushion or a head support or a nest, we need to know why they need it and the benefits of it. I often see nests and incubators, and sometimes they're put together and they're not offering any support. If we're going to do proper infant and family-centred developmentally supportive care, we have to have qualified staff at the cot side driving that framework so that everybody there, parents and healthcare professionals, understand where that infant is at in terms of their motor development, where's their brain development at, where's their sensory development. My child, through her behaviours, was telling me that the environment was disturbing her. It was too bright, it was too noisy, she wasn't being supported, her motor system was being compromised. There was a nest, but her arms were out over the side of the nest, her legs were out over the end. It wasn't supporting her motor development, it was making her uncomfortable, and she was squirming and agitated, telling us this, and we ignored it. So I think helping everybody understand what these babies are saying and where their development trajectory is at is so important. Just remember, these babies are not meant to be here. They are meant to be in utero, developing happily. And that environment has been taken from them. And they are now navigating development in an alien environment. And it is incumbent upon us to understand the challenges they're facing and how we can support them as best we can. If we do not do this, their brains develop differently. Their neuronal pathways are different from your term baby. And then we have infants who have behavioral challenges, developmental challenges, learning challenges, emotional challenges later in life. I wish somebody had told me how important sleep was. We all know NICUs are loud, they're bright, there's a lot happening. How on earth are these babies meant to sleep? And the importance of sleep for brain development cannot be understated. The brain needs sleep in order to develop normally. A lot of our preterm infants do not get complete sleep cycles. Do our families even know what a complete sleep cycle looks like? It's about 40 to 45 minutes. And that changes with the gestation of the baby. But how many of these children are getting these complete sleep cycles? What is happening during those sleep cycles is the brain is developing. It's sorting short-term, long-term memories. It's getting ready for life in the future. But if we're constantly interacting with these babies and we're interfering with their sleep cycles, their brain is going to develop differently, and we're going to have children with additional challenges. And this also follows through to the home environment. The importance of sleep cannot be understated. I knew nothing about it, and it pains me to think of how little sleep my daughter had in the NICU. I didn't know what a sleep cycle was, and I wish I had at that point, because I had so much time by myself in the neonatal unit to support her. And in hindsight, I feel useless because I didn't do so. Why do we need follow-up care? Follow-up care cannot be removed from the NICU. It is part of that continuum of care. It's care in the home setting. And it is so important because premature babies upon discharge are not term babies. They are never going to be term babies. They will not catch up with their peers by age 2. They will have a slightly different trajectory. And we need to ensure that this follow-up care is designed so that we can maximize their outcomes. They can reach their full potential, that they have a good quality of life. They can actually have an educational achievement that is worth it, that we have done everything to support them to get to where they should be in life. They can follow those careers that they really want to. Sometimes their pathways are different. I am the parent of a child whose pathway is different, but it doesn't mean they can't achieve. We just need to validate that they need additional supports. And we can only do that if we follow them up and understand what those supports need. We need them to pursue life and meet partners in life and have families of their own. We want them to be able to give back to society, to be active participants in society. And families need follow-up care. What happens to us in pregnancy when we have a preterm birth changes everything. And every day going forward is, I won't say clouded by, but is certainly governed by that preterm birth. And families heal in different ways. It takes time to heal. Some families don't even know they need to heal, and it can be many years later. And if they have a child who is compromised in any way, that healing process is different. And by helping families through a follow-up care program, they can navigate the best pathway for them and for their child so that everybody's potential is actually achieved. And what does follow-up care look like? Like midcalf, it has to be individualized. It can't be task-based. I think that is the one thing about neonatal care. We do things by tasks instead of by relationships. And if we flip how we look at how we approach our work and do it in a relationship-based way, it changes how we interact with our families and our patients. It's no longer X has to be done by X time. It's now a family I'm working with. It's a baby, it's an individual baby with their own needs. And likewise, when it comes to follow-up, we need to be aware that everything needs to be individualized. Everyone has different needs. We need to do it in partnership with our families. They need to be part of that conversation. They are going to be doing a lot of the follow-up in the home setting, but they need to be supported by a multidisciplinary team. These are the team of specialists who we have at the cot side from day one, who are going to be supporting them along their journey once they've been discharged. We need community-based supports who are specialised, who understand the preterm journey, who understand that it can be for life, and who will not dismiss some of the concerns that families raise, and they often find they are dismissed by just people who just don't know. And for me, I think we need to be doing follow-up lifelong. We have so much research now that points towards lifelong follow-up being, I suppose, a good source of data, a good source of education for us, but also it allows us to develop those support mechanisms for teenagers born preterm, for adults born preterm, because there are challenges they encounter and they are trying to navigate them in a world who does not understand that some of their challenges are related to their preterm birth. What was it like when Amelia came home? It was scary. She came home with a condition called bronchopulmonary dysplasia. It was a word. I didn't know anything about it. I knew it was to do with her lungs, but what I didn't realize was it also impacted so many other parts. So for bronchopulmonary dysplasia, she had a really compromised respiratory system. She was constantly unwell. She constantly needed medication for lung infections. She never slept. And that is not one word of a lie. My child struggled to go to sleep at night, and it turns out she had a self-regulation problem. She struggled to regulate herself internally to allow her body to relax, all related to her experience in the neonatal unit. Her sensory system was operating at a heightened level, and she really struggled to be calm because nobody calmed her in the neonatal unit. Nobody taught her to self-regulate. Nobody helped bring her hands to her face when she was stressed so she could help self-regulate herself. So many of these body cues that I'm so sorry I missed out on. But I spend a lot of my time talking about them, so I'm hopeful that families today are better informed. Amelia never slept, and I never could understand why she never slept. She'd sleep for a small time and wake up crying, screaming, crying, not just crying. And I would have to sleep with her in an upright position, and that went on for years. But it turns out that babies who have bronchopulmonary dysplasia really don't like sleeping on their back. It's uncomfortable. Hence, they wake up in pain. Little things like that would have made a big difference to my life at home. Amelia had an oral aversion, which I didn't realize. So an oral aversion is where she did not like to take anything by mouth, food, anything. She never played with toys, never put anything in her mouth, really struggled to take medication because it has to go orally. And because she was sick a lot because of her bronchopulmonary dysplasia, getting medication into her was really challenging. I'd never heard of an oral aversion, but it does relate to the negative oral experiences that children have in the neonatal unit. So intubations, CPAP masks, any of that mouth care that we do, it's really important that we are cognizant of giving these children positive experiences just to mitigate some of the negative stuff that we have to do to keep them alive. But if we have too many negative experiences, we're going to have kids with oral aversion. Oral aversion is hard because children don't want to eat. And for preterm babies, it's all about putting on the weight and getting them up to their peers. And for me, I'm so sorry that there was so much emphasis put on how much food the baby was eating, what their weight was. Like, I would much prefer if we shifted our focus to the baby as well, and if there seems to be an issue with feeding, let's have a think about what it is. It's not that you're not feeding the baby enough. It might be that the baby has an oral aversion, and maybe we need to address that. Amelia had a lot of sensory issues emerging very, very early on. I thought we had 5 senses. Apparently we had 8. And there were 3 senses happening in our household that I had to do a lot of research on to understand why my infant had issues with balance when she was trying to walk, why she had issues with not being hungry, not understanding when she wanted to use the bathroom. So her interoception sense was compromised by preterm birth. But these all happen in the NICU when their brain is developing. And if we interfere with that normal trajectory, we have infants who have sensory processing disorder. My child had motor issues. She has dyspraxia. She really struggled with her gross and fine motor skills. Again, we were navigating these at home, and I wasn't aware that these could be an issue. And as a parent, you don't often know that this is different. If you don't have previous children and this is your first child, this may be normal, but it doesn't feel normal. And certainly being heard was challenging. Even accessing community care was hard because the minute you would say my child is a preterm infant, the local doctor would go, I don't have a lot of experience. I think you might need to go to the emergency room. And this really was more isolating for us as a family. It's hard enough bringing a preterm baby home and nobody understanding. And sometimes you have to keep the babies in quarantine because there's RSV circulating. Finding that the support in the community was non-existent was frightening because then that actually heightens the burden on me as a parent to make sure nothing went wrong. And things were going wrong, but I was accessing care very, very late. My daughter experienced pain in a different way to the rest of us. So she interprets light pain the opposite way to us. So if she breaks an arm, she doesn't feel it. If she has a cut, it's like somebody has shot her. And translating that into something that's real for a child in a school environment or for her teachers to understand was difficult. Schools do not have experience of dealing with preterm infants. They don't have an education module that helps them understand the long-term effects or how they can manage them. Follow-up can be sporadic depending on where you live. It generally ends at age 2, after which time you're left to your own devices. And you're in a community care system which doesn't recognize that prematurity is for life. Therefore, you are lumped in with the term babies. So anything your child is not doing is never connected with prematurity and is generally picked up late. Explain to schools that you have a preterm infant who's coming to school is interesting, because I think what they expect is they expect a very small child to turn up on the first day. And when your child is the tallest in her class and looks perfectly healthy, but does have some underlying issues, you get that impression from the school authorities that they're not 100% trusting of you. They think you may be overprotective. And then when they do see things in the classroom situation emerging, whether it's a reaction to a smell or a sound, or maybe in physical education, your child isn't able to do things as quickly as others, they rarely make that connection to preterm birth. And as a family, I spend a lot of time having conversations with the schools, reminding them about the different challenges that preterm infants experience and that they need to approach these kids differently. They cannot be comparing these children's physical education performance with a term infant, because these children may have dyspraxia, they may have sensory issues. And again, it falls on deaf ears a lot of the time. For me, there was a massive lack of awareness, a public awareness around preterm birth. And that was challenging because it had happened to us. It happens to millions of people around the world. Yet so many people have no idea what it is. So many people think these babies are small, they need to catch up weight, and they're normal. And oftentimes that isn't the case. So fast forward 19 years, what do we still have? We still have bronchopulmonary dysplasia. Lung health has definitely improved, but I have seen my child suffer with RSV at the age of 16, and I genuinely have never seen her so sick as when she was in the NICU. So there's always that underlying fear that something that is normal for the rest of us who are healthy can manifest in a very different way for an next preterm infant. And having our emergency services and our teams of medical professionals in emergency departments recognize that was very challenging for me as a family. And I have a medical background, so I have the lingo, I can have those conversations, and I experienced a lot of closed doors when I was trying to explain the links between preterm birth and some of the issues that are emerging in adulthood. The oral aversion has turned into something called avoidant restrictive food intake disorder, which is it just means she struggles with food. She struggles with textures, with smells, and has a very limited intake of foods, which has become more difficult since she's been diagnosed as a celiac and she has a dairy allergy recently. So things are happening as they get older that we don't anticipate, that no one tells us they might happen. They might be related to preterm birth. And you feel it's there every day. You feel it's there every morning when they get out of bed as they struggle to get down the stairs because their brain hasn't clicked in, where they're struggling to eat food before going to school. They're anxious about going to school because they're slightly different from others. And that doesn't go away. The sensory issues are there. Some get better over time, some don't. Like, if your child goes to a school with a school uniform and your child has issues with textures and seams, that's going to be problematic. And it's good to know that there are options. You need to find a school that maybe doesn't have a school uniform. And we've had to navigate a lot of those challenges alone. Medications are still challenging from the oral aversion perspective. So if you don't take something orally, how are they going to get meds when they're sick? Intravenously, and that means hospitalizations. And that's back into that preterm birth is still there. It's still, the legacy is still there, and it still affects them. Motor improvement does not really happen. Dyspraxia is what it is. Infants suffer with motor dysfunction for the rest of their lives. We could have changed that. We could have done better in the NICU. We could have provided better motor support to our infants. Executive function often tends to be compromised. What does that mean? It means we struggle organizing ourselves every day. That's okay when you've got a mom or a dad to do it. But as you become an adult, and if your executive function is compromised, how do you navigate life not being able to make decisions? Emotionally, it's very difficult. A lot of our preterm infants have heightened emotions and struggle with their emotional regulation. And again, it's fine when you've got a family support network, but when you enter the world as an adult, how do you manage that? Who's there to support you then? The pain issue still remains the same. They still interpret pain differently. We need to have better pain protocols. families need to be part of those praying protocols. They need to be part of that, ensuring that their babies are receiving the best possible care with the least possible pain, because pain affects neuron pathways in the brain and the brain forms differently. There's a lot of health anxiety in preterm infants because they spent a lot of their early childhood attending hospital appointments, getting new illnesses. That anxiety builds up into adulthood, and we have a lot of increased anxiety around health in our adult community. Oftentimes they learn different. They learn by movement. They learn through learning from hearing music. And the school situation isn't always cognizant of that. They can struggle to accommodate the way they learn. So if we want them to maximize their educational outputs, we have to look at how we can do that. And sometimes it's not the typical pathway. And then having an education system adapt their pathways can often be challenging. So adults who are born preterm, we have so much research that tells us how it is for them, how life it is for them. But what really irks me is we do not translate this into practice. We have longitudinal studies going back 40 years that have followed preterm babies for 40 years. We know they have increased risks of cardiac issues in adulthood. They have increased risk of respiratory issues. We often see preterm infants being misdiagnosed in childhood with asthma, and it's actually COPD that they have, and we're not treating it early enough. And when they get to adulthood, we're looking at early emphysema. We know that cognition issues in childhood, if there's a deficit, they don't miraculously disappear. They continue into adulthood, and that affects their ability to perform in education and in their careers. Preterm infants have increased mental health issues. I've already alluded to the anxiety around health, but we see increased issues of bipolar disease, psychosis, increased use of medications, increased incidence of autism spectrum disorder, attention deficit disorder, ADHD. They struggle with relationships. We see them have different relationships. We see them have fewer relationships as they go into adulthood. We know a lot of them have lower IQs than their term peers. They have less children. They have an increased incidence of preterm birth. They have an increased incidence of stillbirths. They have increased incidence of dysglycemia in adulthood. They do not get the same education opportunities that their term counterparts do. They don't reach their potential because the education system is geared towards term infants and is not flexible to allow them reach that pinnacle of their life potential. And that follows through to the careers they pursue. We see a lot of our preterm infants in manual careers versus academic or managerial. And that's sad. It means we're not supporting them after discharge. They are being compromised. Their quality of life has been compromised. Their health has been compromised. And we're doing nothing. We have the data that supports this, but nobody's taking on board to do something. I do a talk called Prematurity is for Life, because for me it is. It's there every single day of my life. It's there first thing in the morning and it's there going to bed at night. I see it. We do need better follow-up. We need lifelong follow-up. We need that to be multidisciplinary in nature, not just one doctor. We need to look at changing our health system so that we have subspecialties who are specially trained to manage ex-preterm infants as they enter adulthood, so that we can fast track these adults when an issue begins to arise, that they're not made jump through hoops to go to different specialties to try and get an answer. And we need these subspecialty to be all-encompassing. So what I mean by that is, because we have so many health issues for our preterm infants, cardiac, respiratory, nephrology, mental health, we need all of those voices around the table. And that's a very different picture to what we're used to. We're used to cardiologists not talking to respiratory consultants because they stay within their own field. It is different for preterm infants. Their entire body is preterm. Every single cell is preterm. And that results in different things happening as they grow older. We need a community of healthcare experts to facilitate that follow-up for life. We need people to recognize the importance of asking the question when somebody goes to their GP for the very first time, or they go to an emergency department, what is your birth story? Because your birth story determines the care that is going to be delivered. If my birth story is I'm a term infant versus my daughter's who's a preterm infant, there's a very different picture. So if we have a GP who knows that I'm a preterm infant, once they realize that that birth story is there, they will need to be thinking differently than when they're dealing with the person who was born at full term. And I think we need to make it obligatory. It needs to be a question that's when you enter school, when you enter a GP surgery, it needs to be everywhere. Understanding someone's birth story is so important. Public awareness about preterm birth is still very poor. We still think preterm babies just need to grow and go home. And we need to do more to normalise the conversation around preterm birth. We have over 13 million babies born preterm every single year, yet our society has not adapted to facilitate their growth. We need to do better research. We need to do longer research, and we need to do research in tandem with our adults born preterm. They are the ones who can tell us what matters most to them. They will be the ones who will tell us what has not worked for them on their journey to date and what we should be doing. And we need to change systems. We need to be looking at our education systems, our health systems, and looking to see where there's more flexibility, what we can do to make things better. I'll talk a little bit about the organisation I set up. It's called the Irish Neonatal Health Alliance. I set this up because there was nothing in my country to help families who had preterm babies. I set it up to support families. It has morphed into something so much greater. The 5 pillars that we work under are advocacy, awareness, education, research, and of course, support. For me, it was a safety net. It was shoring up the gaps in my country that I knew existed when we were discharged. It was to make my future better. It was to make my daughter's future better. It was to help other families not have the same experience we had. What do we do in terms of advocacy? Our very first thing was to look at the country in general and say, what's happened here? What does it look like? What does the neonatal landscape look like? We did a mapping exercise. We asked every single person who worked in neonatology, nurses, doctors, allied health professionals, what was working and what wasn't working. It was the first collaborative effort. Our organisation is a collaborative platform of multidisciplinary stakeholders, the first of its kind in our country. Everybody coming together under one umbrella, working together and looking at what's working, what isn't working, and what can we do to make a change that's going to be sustainable. We published a benchmarking report which had only five findings. We are still working towards those 5 findings 20 years later. We did not have a neonatal transport service that worked 24 hours a day. We did not have national neonatal guidelines. We did not offer education on neonatology to staff in Ireland. The public awareness around preterm birth was non-existent, and we had no screening programs. We have done a lot of work in 20 years. We now have a 24-hour neonatal transport system. We have neonatal guidelines in place. We have better education for staff. We now have extended leave for families. We have done campaigns during COVID to ensure that families were kept together with their children while they were in the neonatal unit. We have definitely raised public awareness. What we haven't done so far is get into that screening. And I guess the research probably isn't there currently to support it. There are some screening programs that will help us identify early signs of preeclampsia or early preterm birth. We're still working towards that. But that blueprint has steered our work for the last 20 years. And it was so important to do it collaboratively because I think advocacy is difficult done alone. It cannot be done alone. It has to be done including all stakeholders. And sometimes that's difficult, that even bringing them around the table is actually quite difficult. We've done some strange advocacy work, which you might think is a bit unrelated. But what it has done is it has actually shown the level of trust that our health system and our government has in our organisation. We've been invited to help the government and the Ministry for Health look at the role of our pharmacies. Pharmacists are very qualified individuals, but in our country, if you need a prescription, you need to go to your GP. If you need a prescription renewed, you need to go to your GP. We have now worked actively with our pharmacies to help give them the authority to renew prescriptions at the pharmacy counter. We are now about to launch what's called a common conditions service. So pharmacies can now prescribe, instead of me having to go to my doctor for something like sinusitis or rhinitis or a urinary tract infection, we can now go to our pharmacies and they will be able to perform an examination and prescribe. And it frees up our general practitioner service to see people who are actually sick with more complicated conditions. We've become actively involved in health technology assessment for the recent RSV immunisations, for both maternal and for infants, trying to get our governments to understand where they need to be putting their money to make health outcomes better. And we do a lot of work around clinical guidelines. We take maternity, bereavement, neonatal and paediatric clinical guidelines, and we work with our healthcare professionals to update them and develop new guidelines in some instances with the patient voice embedded throughout. I mean, the patients are the ones who we are developing health services for, and they should be the ones who are part of the conversation around developing those services. We've done a lot of work around raising awareness. We look at who our audience needs to be. We look and see what knowledge is there nationally and internationally around preterm birth. And then we have a look and see, okay, how do we increase our visibility? Because by increasing our visibility as an organization, we're helping people indirectly. If people know more about preterm birth, 1 in 10 babies is preterm. Somebody is going to have a preterm baby, and hopefully remember a social media campaign we had or some of our media campaigns and think, I remember some information. I know where I can go get some help. We need to normalize the talk around preterm birth. It is so prevalent and it's not decreasing. We need people to understand that there's things they can do, and we can only do this by leveraging our media, by having awareness days. So World Prematurity Day, World Preeclampsia Day, World Health Day, World Mental Health Day, all the bodily functions that are compromised by preterm birth. We will use those opportunities to raise awareness about preterm birth, because by raising awareness and by empowering people, we will reduce the number of preterm births. If people are more educated and informed, they can make more informed decisions about their behavior during pregnancy, hopefully. Education is something I am passionate about. It is education and research is where I work in the organization. I spent a lot of time developing curricula to help families antenatally in the NICU and after discharge, to empower them to be the best they can for their infants, to ensure their infants can reach their full potential. I develop curricula for families. I deliver workshops. I go to secondary schools and I talk to children, young children, 15 years of age, about preterm birth. 1 in 10 of those children is going to find themselves in a neonatal setting. We do not talk about it until it happens to us, and that is too late. I talk to medical students. I talk to nursing staff, to healthcare professionals, to allied health professionals. I develop curricula. I have lecturing posts in different universities, and I talk to them through the lens of the patient. The science is there. It is not my job to deliver the science. The science, for me, can stand alone. You have to be able to understand the journey through a patient's lens, because that is the impact you're going to have on that person for the rest of their life. Their experience of how you made them feel will definitely change them as a person, but it will also help families of preterm infants. If I have a good neonatal experience in a NICU and I feel empowered and educated and supported, I'm going to bring that home with me after discharge, and my infant is going to be better as a result. I do a lot of work in research. I mean, in the introduction, I've been involved in over 70 international studies on neonatal outcomes. I help now young researchers who are entering training to understand the value of working with the patient community, hearing the patient voice, understanding what their needs are, and then ensuring that the research that is developed is appropriate and meaningful. I work with industry partners, often around medical devices for the neonatal unit. Again, having them understand the patient journey helps them develop a device that actually works for families. And that, actually, I'm going to just give me 1 second. My battery, my laptop is running low. I do apologize for this. My apologies. So we work with industry partners so that whatever they're developing is appropriate to the infant, to the family, and it's acceptable to families. We've done a lot of work around...
For 1 second. We just wanted to ask you to speak a little bit slower so that the interpreter will be able to follow you. Can you?
No problem.
Thank you, sorry.
No problem, no worries. We do a lot of training of patient experts. So patients like me, we work in the field and we call ourselves patient experts because we bring our expertise to a table that isn't there already. We bring the personal lived experience, we bring the patient lens, we bring a lifetime of living with a preterm infant, and that needs to be integrated into research, into academia, into health service development. There are 2 platforms that we use to educate patient experts. One is the UPATI platform and one is the IPOSI platform. UPATI is a European platform and they offer free education modules that are open to everybody. I'm leaving the access to them here. They're links on screen, and the IPOSI is an Irish version. What we do is we help patients understand how clinical trials happen, how they're designed, how patients are a really important part of that process. We help patients understand how medicines are regulated and how patients are a necessary part of that journey, how health systems decide what they're going to pay for. That's called health technology assessment. And also we talk about research ethics. Up to now, research ethics has been a field where patients simply haven't been involved. Research ethics happens in another sphere, but it's so relevant to the patient community. We now offer training on research ethics because in Ireland we have a national research ethics community, and it constitutes patients, families, healthcare professionals, lawyers, industry partners, because they all bring a very unique perspective when we are looking at a clinical trial and how appropriate it is for our research, for our patient community. I've already mentioned clinical guideline development. We've just developed an education module for the public so that they can become actively involved in clinical guideline development, because now we are recognizing the value of working with patients in everything that we do. And ultimately, when we have patient experts go through, I teach for you, Patty, and I, POSI. When we have our students, when they graduate, I offer mentorship for them because I've been doing this job for 20 years and I've seen that to new students, I think is really important for me. A lot of the work that I do is based on what I've learned, and I have developed toolkits for students so they can navigate healthcare, academia, industry, taking my learned lived experience and I suppose not making the same mistakes I've made. And with you, Patty, now we also offer 2 modules called Foundation and Essentials that are for industry. So industry who wants to work with the patient community, be that developing a new product, whether it's a pharmaceutical or a device, they need training how best to interact with the patient community to get the best out of their development process. I've mentioned I've done a lot of research over the last 20 years. My title is Embedded Patient Researcher, and I'm very proud of that because that is ultimately what I am. I'm a patient embedded in the research sphere, but I'm bringing a very unique lens to the conversations that happen. I've done a lot around the work of core outcome development sets because I believe a lot of the research we do is duplicated, is often not relevant. We don't always gather data in a way that we can use in a larger sphere. And by talking to families and patients affected by specific illnesses, we learn what's important to them. And what's important to them needs to be what we're capturing when we're conducting research. I work with a funding agency who gives money for research to happen. So now any applications for research studies will come to my desk. And if I see that patients have not been involved in those early conversations, if I cannot identify the impact of this research or how patients are going to be, how they're going to work with patients throughout the research, the funding doesn't happen now in Ireland. It is so important that we have patients at the heart of all the research cycle. I've mentioned we have a Research Ethics National Committee, which values the patient input. I also work with our Medicines Regulation Authority. So once medicines are regulated by the European Medicines Agency and they get a marketing authorization in Ireland, we have a group of patients we work with now who help the regulators understand the value of the material they produce, ensuring that medicines regulation is delivered in a lay technology format, and I suppose bringing that additional lens to what would have been heretofore a very isolated, unknown area, certainly in my country. And I've done a lot of publications in peer-reviewed journals as well over the years, again, through the lens of the patient. And I think it's important that we capture that because it has been ignored up to now. A lot of our journals take research, publish, and it's left there. And for me, the bit we're missing in terms of research is that translation part. We need to be doing better at taking the findings of research and making it happen, making it be relevant for our patient community. Public and patient involvement, it's working in and co-creating in collaboration with patients, carers, families, service users of the public. And the term PPI is used internationally. It's called different things. It's patient involvement, it's called patient collaboration, patient partnership, but ultimately it's working with patients, whether it's in research, academia, healthcare, in whatever sphere, but working collaboratively and working through the lens of the patient community. This is an infographic that I've designed for my students. It shows where patients should be involved in research, and it's quite comprehensive, and it often frightens researchers when I show it to them. So well, if we start at the start, patients need to be spoken to before we ever do research to work out what are the gaps in their illness, what's not happening for them, what would be a priority for them. Patients need to be part of grant writing because now patients are part of funding agencies. So if you work through this entire cycle, you will see patients designing studies, overseeing how studies happen, making sure that the data that's gathered during studies is appropriate and is safely guarded. A lot of the work that I do is in governance in clinical studies. Patients need to be asked, when data is collected in a study, how do you interpret this data? How relevant is this to your community? What can we do with this? What can we do to leverage this to make something different? And the patient community is so important, disseminating research findings. They sit on shelves most of the time. They appear in journals, but they never happen in real life. They rarely will come into the bedside. And I think that is where we need to harness much more of our patient community to help us translate it into something meaningful and practical. And I've already alluded to authorship, medicines regulation, health technology. Patients are now very much being part of the registry design. So we have a registry in Ireland for therapeutic hypothermia. We were doing it. We were cooling our babies in our maternity units. We didn't really have guidelines. We weren't really gathering data about who was doing what and when was things happening. And we decided these babies are not having good outcomes and we are not following them up. When we put together a registry, we were able to retrospectively look at all the cooling that had happened in our country and have a look at what hospitals had better outcomes. Why were they having better outcomes? What guidelines were they following? And it helped us design guidelines for conducting therapeutic hypothermia. It helped us focus more on outcomes and what mattered to families and the experience that families had. So registry co-design is so important in terms of improving outcomes and in terms of improving procedures. I think it's also important that we use our patient community when we do research, that they can present on that research at conferences, at study days, because they are part of that process. This is a very busy slide, but I think it's one worth taking home and reading very carefully, because what it does, it takes every part of the research roadmap and it tells you all the things that the patient community can do for you, the researcher, at that particular junction of that research cycle. What we've done recently is we've added drug repurposing. We all know that very little has happened in terms of new drugs in the neonatal field in a long time. But what we're looking at now is we're looking at lots of drugs that for which marketing authorization is there already, for which the studies have already been done. And we are now entering that sphere in the hope of repurposing some of the drugs that are currently being used for other indications with a view to maybe improving outcomes for preterm infants. And that's just a very new thing that's just happened in the last couple of years, but it's a very exciting place to be because it will reduce the cost of research because a lot of the efficacy and the safety has been done earlier. And it will also mean that we can speed up the process because clinical processes are so long. We're 15 to 20 years to develop one drug, and it's very, very expensive. And for neonatology, that is why drugs have not been developed. The market is so small and limited, the profit is almost non-existent. So by repurposing, we're hopeful that maybe in another 20 years, we'll have some more drugs that will help us improve outcomes. I do a lot of work in the clinical audit space, again, because if we don't look at how we've done things, we're never going to learn from improvements. We need to understand where the gaps are, why are things not happening like they should be, and helping systems improve, ensuring that government and ministry financial resources are steered towards areas that need improvement and support. We do a lot of work in system reviews, looking at neonatal systems in general or pediatric systems, and again, identifying gaps and where we as a patient community can support our Ministry of Health in improving them. It's only through living through a journey that you can see some of the things that a healthcare professional is never going to see because they have not experienced the journey through your lens. Quality improvement and patient safety are becoming much more prominent. And I think certainly in terms of, of working with patients, understanding what could be done better and how they can be done more safely for patients is more important. But having support mechanisms in place so that patients who have poor experiences can feed back into our health system they're essential. We are never going to learn if we do not listen to when things go wrong and we do not manage them in an appropriate fashion. As an organization, this is why we started. We offer support to families. This is what I needed when I left the NICU and I did not have. And I made it my mission to ensure that when families leave now, they have so much more and they feel more supported in the community, because that transition to home is still not happening. We have a comprehensive website. We have a parent forum that is managed by healthcare professionals. So when families have issues, they can go to this forum and they can be signposted to accessing interventions. We hold education workshops for families. We have so many publications to help families navigate from antenatal right up to adulthood, and all our publications are free to download. With the helpline, we offer peer support, and two of our very successful ventures, we hire out breast pumps to mums. It was so challenging 20 years ago and expensive, because you bring a baby home and you have to hire a breast pump. You have prescription formula, which costs a lot of money. You have a baby who's on an MR10 breathing monitor. All additional expenses that you haven't factored in when you were getting pregnant, and there's no support for it. So we have worked with our government to ensure that there are some tax incentives for families who do have to rent medical equipment, but we have bought our own pumps so that families can just access them directly. It is so important. We know the benefits of breast milk, but we do not support it in the way that we should be doing still to this day. And we have NICU milestone cards, which are probably our most popular adventure, I would say. It helps families capture those lost memories. It makes new memories for families. The baby wearing clothes for the first time, the baby transitioning from intubation to CPAP. Mightn't be everyone's idea of making memories, but when you've lost so much, capturing those positives is so important, because when you look back at your journey, part of your healing process is accessing some of those positive experiences, because they will shape how you are as a parent going forward. And for some families, all they have are the milestone cards. Their babies don't make it, and they are even more important for them then, that they capture those moments with them. So my journey, it's been a long, quite a circuitous journey from 2006 to 2025. My career has seen me move out of radiology into neonatology. It's a career path I wouldn't have chosen. It was clearly chosen for me. It's been a eye-opening journey. It has been a learning journey. Every single day, I see change. I see preterm birth every single day. It gets out of bed in my house and I see it go to school, navigate life, navigate the world. I am so fortunate that I have been in a position to take my learned experience and translate it into so many different learning opportunities for those involved in the field. I did start only wanting to do this as a support mechanism. It has turned into so much more. And I do hope that you have gained some insight into my personal journey, my professional journey, and what the potential is in every single one of us to make a change for these babies and for their families, because it is life-changing, but we can make sure that that change is actually for the better, and we can make the most of what life throws their way if we support them right throughout their lives. And I cannot emphasize that. Lifetime support, system change, validating how difficult it is at outset, and supporting them to get to a point where they are strong enough to take the reins and be the primary caregiver. And you know, for me, it's handing the voice over. I've been the voice of my child for 18 years. It's now time for me to say, this is your life. We've done this together. I will always be here. And all the support mechanisms hopefully are there for you. But now it is your voice going forward. You are the one who's going to have to talk about your birth story. So if you take nothing home today, it's about lifelong follow-up. It's about the importance of birth story, and it's about empowering families. And thank you for listening.
Доброго дня всім. Я трішки запізнилась на наш вебінар, але чула більшу його частину. І тому, що я запізнилась, тому перші питання, які є, будуть ваші, Ірина Юрівна. Будь ласка.
Я дуже дякую, Менді. Я багато чула про вас від Асоціації батьків передчасно народжених дітей в Україні, але скажу відверто, я вражена вами і особисто записала 3 або 4 сторінки за вами і навіть пропозиції для подальшої співпраці з Україною. І мені дуже, перед тим, як я задам перше запитання, мені дуже відгукнулися слова, які ви сказали на початку, що коли ви повернулися з дитиною додому, ви не відчували себе матусею, ви відчували себе піклувальником та щось на кшталт неонатолога, фізичного терапевта, спіч-терапевта та терапевта ще когось разом. І хочу вам сказати, що наші вебінари, в яких і ви приймаєте участь, дуже відрізняються від стандартної української системи навчання лікарів і медсестер, тому що ми, на жаль, досі не маємо досвіду вислуховування батьків дітей, яких ми так героїчно рятуємо. Тому моє перше запитання саме з цього. Я знаю про вашу участь в написанні європейських стандартів догляду за передчасно народженими дітьми. І знаю, що там була і медична частина команди, і батьківська частина команди. Чий голос був вирішальним, коли не було консенсусу?
Families. There's just one answer to that. Families. I think the way that project was designed, it was designed by families for families, and it was in collaboration with all the stakeholders, and it was made very clear at outset that every voice mattered around the table, but it was recognised that the current neonatal system that exists had no familial input. So the importance of integrating the family perspective was, I think it was heightened from outset, and I think those medical professionals who were chosen to participate in that particular project, I'm going to say, are probably pioneers. There may have been some dissenting voices who really struggled with families, but we were so much supported by those healthcare professionals who, I'm going to use the word got it or understood the importance of the lived experience, that it was easy to win over those questioning voices because their peers were around the table with us, supporting us. So we did, I think it's always necessary to have champions from healthcare professionals who hear voices, because they are going to be your door openers to converting those who might still be a little bit suspicious about listening to family.
І друге запитання від мене. Ви багато сконцентрувалися на порушеннях сну у дітей після виписки з неонатальних реанімацій. Скажіть, будь ласка, декілька порад саме медичній спільноті, лікарям-неонатологам, медичним сестрам, які, за підтримкою яких відбувається виписка дітей додому. Які поради ви, як мама, яка пройшла цей шлях, дала би нам, фахівцям, що б ми мали би радити батькам, коли вони стикаються, а я впевнена, як людина, яка 35 років виходжує цих дітей, що майже кожна така родина з такими проблемами стикається.
I really think a lot of our healthcare professionals don't have sufficient knowledge around brain development and sleep cycles and the importance of both. If we improve our medical student and nursing curricula to incorporate those topics, by the time they get to the cot side, they will have a better appreciation as to how important sleep is and how the lifelong effect that sleep deprivation can have on a child. And it will enable them to have those conversations with families. And families are at our incubators for hours a day. They are the best gatekeepers to protecting their baby's sleep. So if we empower them in all aspects of parenting from day one, it means that their voice is going to be heard equally. So if something is happening in a neonatal unit that is loud, that is unacceptable, it should be okay for a family member to say, can we take this conversation into the hall? This conversation is disturbing my baby. It's disturbing his or her sleep pattern. And being able to recognize sleep patterns, teaching our families to recognize where in their sleep cycle their baby is. I didn't realize we had 6 different behavioral states. I wish I did, because I was witnessing them every single day, several times a day, 14 hours a day. If I did know that, I would be able to advocate better for my baby. So if there are healthcare staff who may be having conversations, just not necessarily about that baby, but anything, they're inappropriate. But I think we need to change the atmosphere and the culture within our neonatal unit to including our families within the unit, educating them around sleep cycles and the importance of that and brain development. And likewise, when they go home, if we do that in the NICU, they will carry that into the home setting. They will be used to watching their baby. They'll be used to watching what sleep cycle their baby is in, what behavioral state their baby is displaying, and they will be able to tailor their interactions with the baby based on the experience that they have got while in the neonatal unit. I felt it was a missed opportunity to upskill me as a mom with the neonatal, the nursing, the OT, the physiotherapy skills that I could have used in the home setting that would have benefited my baby. And I think the neonatal unit is that window of opportunity that we are just not harnessing. But we need to actually support our staff with better education around these so that they can then help families. And I think we're still not there. I think we need to go back into 3rd level. We need to look at medical students, nursing staff, or occupational therapy curriculum. So do they have the necessary skill set to translate that into practice? And if they don't, that's where we need to start beginning the conversation.
Менді, ми маємо 2 запитання від моїх колег-неонатологів, які ґрунтуються саме на тому, що ви маєте унікальний досвід. Ви лікар і ви мама передчасно народженої дитини, яка пройшла весь цей шлях. Скажіть, будь ласка, з огляду на те, що Україна станом на сьогодні не має затвердженого стандарту тривалого спостереження, ваші рекомендації, які об'єднують оці 2 ваші унікального досвіду, частини, коли повинна починатися умовна реабілітація передчасно народженої дитини, коли вона ще на СІПАПі, в інкубаторі, що для лікарів повинно бути отим показником, що дитина вже витримає фізичну терапію, ерготерапію, навіть заняття зі спіч-терапевтом? Це перше запитання. І друге запитання, до якого року мінімально ми повинні були би прописати в своєму національному стандарті спостереження? Чи залишати як на початку в світі до 2 років, чи все ж таки відразу закладати більш тривале спостереження з огляду на всі ті результати досліджень, які ми зараз маємо?
Good, great questions, really good questions. My experience to date has been, if we do not have occupational therapists, physiotherapists, dietitians and speech and language therapists at the cot side from day one, we miss an opportunity. They are the professionals who from day one can facilitate best supporting that infant's development, and they are the ones at discharge who need to be sitting around the table to get with a plan before the baby even leaves, because it is very obvious. I'll take an example. In the NIDCAP Federation, we have a developmental tool called the APID, which is done prior to discharge. And it's an assessment tool to assess these infants before they go home. And it can help us flag those babies that are going to need that additional help. So there are several tools out there. but you also need the eyes and the ears of that allied health professional team together, talking about their journeys with that baby and what they've been observing. It is very simple. I mean, if I had my time back again and I took my diary, it was so obvious that my child was going to struggle with her motor skills and her sensory skills. Things like emotion, you cannot determine. That happens over time. But some of the more concrete and more easily identifiable issues are identified by qualified allied health professionals before discharge, and those babies can be flagged for additional help. Obviously, gestation plays a huge role. The younger gestation babies need to be followed up much more closely. But I'll say that with a caveat. We know that our babies born between 33 and 36 weeks have a lot of educational problems. They have a lot of emotional problems, and that does not appear until they go into school settings. So some of the factors that will determine who needs follow-up will be what follow-up you're going to offer. So if you're talking specifically physio, occupational, speech and language therapy, some of those issues are easily identifiable prior to discharge. And it's generally gestation length based or their journey. So if they've had a brain bleed, they're the babies you need to be bringing back later on, because their MRIs, you can't trust, like an MRI will give you a picture, it doesn't give you a story. What age do we need to follow them up until? Okay, in the ideal world, you've heard me say prematurity is for life. For me, discharge happened, like I stopped seeing everybody at age 2. We went over a cliff after age 2 because she went from being a baby to a toddler, going into a school setting. So a lot of those transitions for premature babies are very difficult. And they tend to be the times in life where new stuff emerges. So when we go to school, into whether it's preschool or primary school or secondary school, that is where you start to see how they interact socially, how their behavior may change, how their demeanor may change because their personality is slightly different, how they physically, usually, I remember the first day in nursery school, looking at my daughter and spotting another child in the class whom I didn't know, who had exactly the same issue. She had dyspraxia. Because I could see it, my child had it, but I could see it in another infant, and that child's parents didn't know she had it. But that would become evident, I think, when they go to these social settings, some of their issues become more obvious. So at age 2 is the worst time to stop follow-up. It is the absolute worst time, because a lot of the problems that emerge are later. And it's those transition periods. It's going to school, and then it's going to secondary school because in secondary school they're entering puberty, and that brings a whole bunch of other stuff. Is there an ideal time to stop? In my estimation, it has to be individualized, but there always has to be an open door policy. Because what we are seeing is people, even though they may not have had a lot of issues growing up, when they hit their adulthood, they are experiencing health-related issues, real challenging cardiac issues, respiratory issues, mental health issues, and they are struggling to get heard, to get a diagnosis, because they're too young to have a problem. And sometimes by the time they get that diagnosis, it's too late, and the damage is irreversible. So I think if it were me, I would like to say, please follow up on an individualized basis, based on the picture you're seeing, but have it long-term. Ideally, I think for me, things started to go wrong at about 4, again around 12, 13, and now we're entering adulthood. There's a whole bunch of new health issues emerging. So there are milestones along that developmental trajectory that are important. I'm a great proponent of bringing them back every couple of years. We call it an MOT, it's like a full talks about an exam to see what's going on. And that helps us assess, do we need to see them again? But I think having a cut-off point as a family, I think you're doing a disservice to this generation, because I work with adults in their 40s who are preterm, who are struggling, and whose stories are heartbreaking. So for them, they need lifelong follow-up. But I think having that open door policy is very important. And I think having that multidisciplinary team who can recognize that this issue is probably not going to go away scheduling another follow-up for that infant in 3 years' time is probably better, rather than having a clear cut, we cut it off at age 6, because there is a whole bunch of preterm babies whom age 6 would not be appropriate. So I think it's adopting individualized is the word I tend to use, because all our care should be individualized, and I appreciate that's incredibly expensive to think about. But individualized also ensures better outcomes. As a family, I'd like to see lifetime follow-up, because that is where we're at. And that is something I didn't anticipate. I was waiting for age 2 to happen. I was waiting for that carrot that was being dangled in front of me. I was waiting for that, like 8th of October, 2008, because my baby, who was having a whole bunch of issues, was going to be miraculously fine on the 9th of October. And as a parent, it's really disappointing when that doesn't happen. So I think we need to be a bit more realistic in how we talk about prematurity to families, and helping them understand that there might be emerging issues, but that there's a support mechanism in place to cope with that, to manage that, and help them manage it if those issues do appear. Because for me, when they emerged, nobody would listen to me, because she was discharged. She was termed a normal baby. And it took me a long time to get a proper diagnosis, to get a system to really revisit her and say, oh God, yes, there's a problem. So there isn't a clear-cut answer, and I'm really sorry to not be able to give you a yes or a no to that, but I think it's individualized, and I think it's working from day one in NICU. I think they're the babies that you can flag very early on that are going to be most significantly in need. And I think we need a multidisciplinary team to be working collaboratively and having those very important conversations and using those tools like discharge, like the APIP tool I mentioned. It's a good pointer to flagging those difficult babies who are going to definitely need the issue. It's, the ones in the middle, some will slip through the net. That is just going to be the way. But if we can educate families around what they can be doing at home to spot issues, maybe that would help. Because again, you're talking to families who mightn't have other children. So there's an education element associated with how do we best manage this? But I think education across all spectrums, whether it's families and healthcare professionals, is a good strategy.
Дуже дякуємо, Менді.
Передаю слово вам.
Да, в нас було на цьому зумі багато дуже людей, було навіть десь 263 людини в якийсь момент, і зараз вас 251 людина, за що ми вам дуже дякуємо, і люди дивляться нас також на YouTube. Дуже дякуємо, Менді, за таку цікаву лекцію, і дякуємо всім, хто з нами лишався і писав слова вдячності Менді за цю презентацію. Дякую дуже, Ірина Юрівна. Буду як в тому анекдоті, не знаю, хто він, але за рулем в нього сам Брежнєв. Ну, тобто я маю на увазі, що ви за мене провели сьогодні весь вебінар. Дуже-дуже вам дякую. Всім дякуємо і бажаємо тихого дня, наскільки це буде можливо, і тихої ночі. Дякуємо.
Дякуємо, Менді. До зустрічі.